Hello, Dr. Osama, we can hear you.
Hello, doctor. Okay, thank you so much. Bismillah ar-Rahman ar-Rahim. Today, inshallah, we will practice a case of station 5, and after doing the case, I will comment on the performance of the doctor and give you an approach of this very important case, and then some vital dynamic advice regarding station 5 and how to make it perfect. So, who want to practice the case, doctors? Any doctor. We are here to learn, no pressure of the exam. We are practicing. So, only any doctor want to practice?
I can take it, doctor.
Okay, so your name is Dr. Julius?
Yes.
Okay, doctor. So, this is a station 5 case. Your role, Dr. Julius, that you are the senior house officer of the medical admission unit. And the scenario, any doctor want to record this session, doctor, and share it with your colleagues on the group, on my group or any other group, it is totally okay. Okay, so this is a 35 female patient, Mrs. Sandra, who is complaining of problem in her vision. Blood pressure normal, temperature normal, and you need to see this patient, assess her, and address any concern she has. You have a real exam, you will be given 2 cases, you will have 5 minutes. Here you will have 2 minutes, Dr. Julius, to start the case. So this is a station 5, 35 female patient, Mrs. Sandra, complained of problem in her vision, blood pressure normal, temperature normal, and you are the senior house officer of the medical admission unit, and your task to see Mrs. Sandra and to assess her condition and to address her concerns. Are you ready, doctor?
Yes, I am.
Okay, you can start.
Hello, Mrs. Sandra, I'm Dr. Julius. I'm the senior house officer, and I'll be speaking to you about your health.
Okay.
Could I go ahead? I've been told you've been having problems with your visions. Could you tell me more about it, please?
Well, doctor, I was totally fine, doctor. It all started about yesterday. It happened, doctor, like suddenly, doctor. I felt that like my vision is not okay. And actually, doctor, it is persisted till now. That's why I'm here today. I'm very curious about my condition. What's happening to me, doctor?
Okay, Mrs. Sandra, I appreciate your concern and we'll try as much as possible to
Thank you, doctor.
to find out the problem. So you say you noticed can you describe exactly what you noticed?
Well, doctor, I think there is pain in both of my eyes, and I see double, doctor, and I think my sight vision is not okay as well.
Okay, Mrs. Sandra, have you had this before?
No, doctor.
Okay, you say you notice pain as well. Is it when you
While moving my eyes, doctor? Yes.
Okay. And the double vision, is it on any direction you move your eyes or all directions?
Both sides.
Both sides.
Yes.
Okay. Mrs. Sandra, do you have headaches along with this too?
Yes, doctor. Actually, it started, doctor, about 3 a.m. yesterday. I woke up with a very severe headache, doctor. I never had it before.
Okay. I'm sorry about that. Are you still having the headache, Mrs. Sandra?
Yes, doctor.
Okay. On a scale of 0 to 10, 0 being the least and 10 being the most,
it is 9 to 10, doctor.
Okay, Mrs. Sandra, I'll offer you some analgesic, some pain reliefs. Is that okay?
Thank you. Okay, doctor.
Okay, Mrs. Sandra, the part of the head that aches you, is it everywhere or is it a particular place?
It is all over my head, doctor.
Okay. Have you had this headache before? This kind of headache before?
No, doctor.
Have you noticed anything that makes the pain worse or brings it down?
Like what, doctor?
When you bend down, does the headache get worse?
I'm not sure about that, but I tried some painkillers, doctor. It didn't help.
Okay. Are you feeling dizzy as well?
No, doctor.
No. Okay. Do you have weakness in any of your limbs?
No, doctor.
No. Okay. Do you also feel like vomiting?
No, doctor.
Okay. All right. So I want to ask also, have you noticed any changes in your weight recently?
No, doctor.
Okay. Okay. Any neck pain?
No, doctor.
Okay. Or neck stiffness?
No, doctor.
Okay. Has there been any change in your temperature recently?
No, doctor.
Okay. Have you observed any weight changes recently?
No, doctor.
Okay. I also want to ask, do you have problems with your color, the color of your color vision?
No, doctor.
Okay. Mrs. Sandra, you also complained that you have difficulty seeing the sides.
No, doctor. In my sight vision, I am bumping to objects.
You're bumping into objects. Okay.
Yes, doctor. Actually, doctor, I feel not comfortable to light as well.
Okay. Why is that?
I don't know, doctor. It started all yesterday. I feel not comfortable at light when I look at light.
Okay. Well, you say you've not had any fever.
No.
Okay. Okay, Mrs. Sandra, do you have any joint pains?
No.
Any problem with your bowel opening?
No.
Any problems with your waterworks?
No.
Okay, have you noticed any skin rashes as well?
No, doctor.
Okay, have you traveled recently?
No.
Okay, I would like to ask you a personal question, and I ask this to all my patients. Okay.
Sure, doctor. Okay.
Did you use any recreational drugs?
No, doctor.
Okay. Sandra, I also want to ask you, do you smoke?
No, doctor.
Okay, do you take alcohol?
No, doctor.
Sandra, how much is this affecting your work?
Well, doctor, I didn't go to work yesterday and today as well, and I cannot cope at home because of this headache and vision problem.
Okay, I'm sorry to hear about that. We'll try and assist you as much as we can.
Thank you.
What do you do? Please, what do you do, Ms. Sandra?
I'm an accountant, doctor, at a company.
Okay, okay. Do you drive?
Yes, doctor.
Okay, please, I would like to advise that for now you hold on with driving and you have to inform the DVLA until we get this sorted out. Is that okay?
Yes, doctor. It's totally fine.
Okay. Do you have any medical conditions?
No, doctor.
Okay. Are you on any medications?
No, doctor.
Okay. Do you have any family history of similar symptoms, Mrs. Sandra?
Well, doctor, my father had a stroke before.
Okay. Sorry about that.
Thank you, doctor.
Aside from that, no family history of anything similar to this?
No, doctor.
Okay. I'd like to examine you.
Okay.
Okay.
2 minutes remaining.
I want to check her hands.
Okay.
Check her pulse and blood pressure.
Okay.
Okay. I also want to do. I want to check her eyes. I want to do a visual acuity.
Okay. It is both decreased in both eyes. What else?
Okay. I also want to do visual field.
No need, doctor.
Okay. I also want to do a fundoscopy for her.
Okay, wait a second. You will hold the torch. You will ask permission from examiners to dim the light. And this is her fundus.
Okay. Okay. So I would like to check the tone, power, and reflexes in her both upper limbs.
No need, doctor. No need.
Okay. I also want to examine her chest.
No need, doctor.
Okay. Sorry, I also would have checked for the eye movement for any symptom,
No need, doctor.
double vision.
No need, doctor.
So, Mrs. Sandra, do you have any complaints? I mean, any concerns?
Oh, yes, doctor. So what's happening to me, doctor?
Okay, I appreciate your concern, Mrs. Sandra. Well, we suspect that you're having a condition called possible subarachnoid hemorrhage. Sorry about don't worry about the term. It just means a condition whereby there's a rupture in the blood channels in the brain that can result in very severe headache and also problems with vision as well. So for this, we're going to have to admit you and also want to do a brain imaging to confirm this. And if that doesn't give us enough information, we may go further to take some blood from the back of your spine and also assess for the possibility of that. We're calling the brain doctors together with specialist nurses to give you the best management that is required in this case. Do you have any other concerns?
Time finished. Okay, actually, I gave you 2 extra minutes, Dr. Julius. So I am the examiner now, Dr. Julius. We will discuss for 2 minutes, and then I will give you the feedback. So what is your differential diagnosis, doctor?
My differential diagnosis is subarachnoid hemorrhage.
Okay. So what else, doctor? What else other differential diagnosis here?
Could also consider an idiopathic intracranial hypertension.
Okay. What else?
And space occupying lesion as well.
Okay. So, doctor, what is your management plan to the patient?
I would like to admit Mrs. Sandra. Okay. I would like to request for an urgent brain computed tomography scan.
Okay.
And
what if it was normal?
If it was normal,
could you proceed? Yes.
If it was normal, I would like to do after 24 hours. I want to do a lumbar puncture. Okay. For her. Yes.
Okay. What else? Do you think there is any rule here for MRI or MRV?
Yes.
Don't say abbreviation to the examiner. You will see magnetic resonance imaging or magnetic resonance venography. Okay. Yes. So, okay. So, Dr. Julius, I would say you did it near perfect. I am very glad by this performance, really. So, what was the catastrophic thing here that you need to do? You are a safe doctor, Dr. Julius. You did the main part here. Any severe headache, any sudden severe headache with vision problem, you need to put number one differential subarachnoid hemorrhage until proven otherwise, and this is the main part here. Whatever other differential, and you did this. You admitted the patient urgently, you offered urgent CT brain, you offered to stop driving, and you offered MDT approach. This was brilliant. But your marking here will not be 28. So any female patient, Dr. Julius, what you need to ask about? What about female history?
Okay.
Right?
Yes.
Yeah, female history here, totally positive. There is OCPs and there is past medical history of abortions, and patient will not volunteer to tell you about it. Any patient or a surrogate in your station 5 exam will have instructions of what information that he will spontaneously tell you and what other information will only tell you about or inform you about if asked. You need to ask about it to tell you about it. So past, like, show me your medication list, please. Two medication patient will not volunteer to tell you, OCPs and recreational or illicit. And female history, if the patient has like 5 abortions before, patient will not tell you about it, except if you ask it about it. So raises what differential here, Dr. Julius? If the patient had 3 abortions before and taken OCPs, so what would be your second differential here, or even first differential?
Cerebral venous thrombosis.
Yes, exactly. And it happened a lot of time before, and it could be any thrombophilia risk factor in your exam, in your history. So you need to ask about it. So how could you manage this case? This case, I feel that all of you now feel that it is a very difficult case. But actually, it is not difficult because you have a very narrow differential diagnosis of acute severe headache. Your differential diagnosis was not totally fine, regardless of subarachnoid hemorrhage, as I told you. So space-occupying lesion and idiopathic intracranial hypertension are chronic headaches, and patient will have it before. So you asked a very clear question, is it first time? I told you yes. So idiopathic intracranial hypertension or space-occupying lesion or tension headache or even medication overuse headache, all of these kind of headaches are chronic. Patient will have it before. Even migraine, patient will have it before, so it is on and off. But the acute headache in your PACES exam, it is 1 of 4. And when you have a complaint outside of a vision problem, you need to ask about headache inside early. This is very important. And when you have a headache outside, you need to ask about vision problem early as well to examine as Dr. Julius examined. Perfect. Well, regarding examination, I will give you full mark, Dr. Julius. You really deserve it. But time management is not okay. You need to start examination early. The only trap you filled in here that you didn't start examination early, otherwise your time management is very good. So any headache with vision problem in your exam, you have a differential diagnosis, whatever the headache is acute or chronic. I am talking about a broad differential diagnosis of headache and vision problem. So when a patient has pain in head and pain in eyes, okay, or even a problem in eyes, like whatever the problem is, visual acuity or double vision or problem inside vision, okay, so you have a differential diagnosis. This is the abbreviation, TIMMSS, TIMS. So T for temporal arthritis, right? Write it, doctor, because you will need it in your exam. Temporal arthritis. I, idiopathic intracranial hypertension. First in here, multiple sclerosis. The other M, migraine. S, space occupying lesion. other S, sinus thrombosis. There is only 2, or I would say 3 acute in this differential. So you have 6 differential. But when the headache is severe from outside, could be given to you from outside in the car that the headache is a severe headache, could be given to you. So you will write down 4 differential diagnoses. 3 of them are here in the headache with vision problem. So number 1, subarachnoid hemorrhage. Number 2, temporal arthritis. Actually, you can add subarachnoid hemorrhage to this differential. You can make it 3S because subarachnoid hemorrhage could present with both of vision and severe headache. Number 3, our case today, sinus thrombosis. This is the differential diagnosis of acute headache. Lastly, pituitary apoplexy. Pituitary apoplexy patient will have a history of endocrinal problem before, or any surgical intervention happened in pituitary, like a patient had acromegaly, and he will not volunteer to do acromegaly. He had a problem in one of the gland in the brain and a surgical history, and then Addison. So patient will have a history of collapse or a history of severe headache and will have Addisonian crisis mostly. So it is mostly a history of collapse, pituitary apoplexy, and it is an emergency. It is a life-threatening. So any severe headache, number 1 differential diagnosis, subarachnoid hemorrhage. After that, you have these 3 differential. So out of 6 here of the TIMS, you have temporal arthritis, you have sinus thrombosis, and you have subarachnoid hemorrhage. This is the headache with vision problem. So space-occupying lesion and the idiopathic intracranial hypertension are headache that is chronic. So it is not in your list when you go outside, so you will narrow your differential inside. When you hear that the headache is the first time the patient had, and it is not on and off, and the patient has no headache before, so you are talking about 4 possibilities, and you will narrow down your possibilities by asking about other questions of headache. So to rule out meningitis, you can add meningitis, doctor, to severe headache here. To rule out meningitis, you need to ask about rise of body temperature and skin rash and neck stiffness, and Dr. Julius asked me about it, so ruled out. Pituitary apoplexy, you can ask about any disease spells, ruled out. So you have now 3 differential: temporal arthritis, sinus thrombosis, subarachnoid hemorrhage. Temporal arthritis, it is a unilateral headache, ruled out. Headache is all over the head, and doctor asked me about it. So you are now talking about number 1 and number 3 here. How could you differentiate? You will not. It is a case for differential, but sinus thrombosis is favored by the history of abortion and patient taking OCDs. So it is a thrombophilia risk factor that you need to explore here. Actually, it happened before that. It was related to Behzet. That's why you need to ask about sores, any painful sores in your mouth or private areas. Even patient could have a past medical history of cancer. It is a thrombophilia risk factor, a prothrombotic risk factor, or patient could be in a postpartum phase. That's why female history is super important here. Patient could have like a delivery 2 months ago. Okay, patient could have a family history of blood clotting. You need to ask about it. You asked about traveling history. This was brilliant. What else here you need to ask? Trauma history, any severe headache, you need to ask about trauma. Regarding examination in this case, well, examination is not difficult here. It is at patient 5, doctors, you are not required to do any unnecessary examination. Examination is focused. So just start examination by the basics, by putting your hand in the pulse, ask for blood pressure and temperature, and then going for pallor in the eyes, and then going directly to examine the complaint, the system of the complaint. So here there is headache, So it is a neurology and there is vision problem, so there is eye. So what you need to do, when you ask about neurological survey in your history, rapidly, focusedly, organized way, any weakness, do you have any weakness in your arm or legs, Mrs. Sandra? No, doctor. So don't do power and blah, blah of upper and lower limb. Do you have any pins and needles or any abnormal sensation? No, doctor. Okay. Do you have any neck stiffness? So no need to do neck stiffness if it is negative. No time for that. Do you have any problem in your eyes? Yes, doctor. Could you please tell me more about it? Well, I have pain. I feel uncomfortable to light. I have double vision, doctor. Okay. If the patient has pain in eyes, don't ever do eye movement without asking permission from your examiner, because it is against patient welfare and this is tricky. So you will start by visual acuity and then tell your examiner, sir, I would like to do eye movement examination. He will tell you no need, and the case will be a surrogate mostly. A case of severe headache, of course, it will not be a real patient coming to you complaining of severe headache in your exam. But you will act like them acting, so you will just ask permission. He will tell you no need. If he told you, okay, proceed, doctor, okay, you will proceed, but gently and sensitively with your patient. After that, visual field, and then fundus. So put in your mind, when there is a vision problem, you need to examine fundus. Examiner could tell you no need, doctor. But in this case, examiner will tell you proceed, doctor. It is totally fine. And I saw a case of, it could be, doctors, it could be a chronic. It could be a chronic. This problem case could be a case of like happened before sinus thrombosis and the patient now has bilateral papilledema. I saw a patient in real life like this. Could be a patient now pretending that she or he has a problem, and the patient, you will see papilledema. So it was papilledema here, and examiner will ask you, what was the finding? I forgot to ask you this question, Dr. Julius. Have you recognized, Dr. Julius, that it is a papilledema? Hello? Any doctor here recognize that it's a papilledema? Hello, doctors?
Yes, it is clear, Dr. Prince.
Yeah, it was
in the boundaries of the disc.
Yeah, it was an ill-defined swollen optic disc. It is totally different from the normal optic disc, and to do fundus fluently, you need to do it in real life. It is not examiner will know that it is first time to have done fundus or you did it before. I know a colleague who did, his case was fundus, and the examiner asked him, doctor, be honest, doctor, please, have you done fundus before? You tell him no. So he will know. Even you need to do it one or twice, go to ophthalmology department in a hospital or do it in real MOCs. In your country, it is very important. It is not very common to have a fundus, but it happened last night in a lot of overseas and UK centers. So you should do it. Okay. So this is regarding examination. This is more than enough. So don't do unnecessary examination. So time management in a case of severe headache is very easy to manage. It's not a problem at all because you have a very narrow differential. Acute severe headache with vision problem, you have one of three possibilities. You have subarachnoid hemorrhage, you have sinus thrombosis, and number three, you have, what else? Sorry, doctor. So it is sinus thrombosis, subarachnoid hemorrhage, and well, that's all, doctor, actually. If you revise TIMS, you will find all others are, well, apoplexy, no, doctor. Apoplexy patient will have these spells, and patient will have a fatigue, will have like Addison clinical picture. So it is not the case here. So it is only two differential. If you revise TIMS one by one, doctor, temporal arteritis, a unilateral headache ruled out here. Idiopathic intracranial hypertension, chronic headache ruled out here. Sinus thrombosis, multiple sclerosis is not the case here. Multiple sclerosis patient will have motor problem, will have sensory problem, and the headache will be mild headache. Headache will not be acute. And patient could have a vision problem related to either blurring of vision or optic neuritis causing pain while moving eyes. Could happen. So that's why it is one of the features, but never acute headache. Okay. What else? Migraine. Migraine headache will happen before. So it is not the case here, ruled out. And then sinus thrombosis, it is number 2 differential here. And space of my lesion, not the case here because it is a chronic headache. So acute severe headache with a vision problem, headache 10 of 10 severity, subarachnoid hemorrhage until proven otherwise, and you need to rule out sinus thrombosis by asking about it. Temporal arthritis happened before in the exam. Pituitary apoplexy happened. Subarachnoid versus sinus thrombosis, very common. Meningitis, it is a differential, but will not be the case in your exam, of course, because it is highly infectious. It is a differential if there is fever, if there is skin rash, if there is neck stiffness. Otherwise, don't put it in your differential. So, if you didn't offer urgent CT brain to the patient here, if you told the patient CT brain without urgent, your clinical judgment could be, if the examiner is a type of a tough examiner, could give you unsatisfactory. Urgent CT brain could be a life-saving, and you need to be a safe doctor. Okay? Urgent admission is a vital here regarding clinical judgment. Stop driving and stop OCDs and offer MDT approach for the patient, including brain doctor and eye doctor. Actually, papilledema here is an emergency as well, okay, to save the vision of the patient. So you need to tell your patient, I appreciate your concern. So how to get full mark in concern? By asking about it at least 3 times. You need to do that. You need to spare a time for yourself to do that by examining the patient early, and then you will have a time to ask about concern at least 3 times. So ask about it, appreciate the concern, show empathy in this case. Well, Dr. Julius, you were brilliant regarding empathy and sympathy. You offered painkillers, and this was brilliant, actually. Offering help for a patient who need help, like here painkillers, is very well done. Okay, so then you will offer MDT for the patient, and then you will give the patient explanation. I appreciate your concern. I'm very sorry to tell you that your headache, Mrs. Sandra, could be related to a serious condition, cold, and then you will give either, if you already know that there is a past medical history of blah, blah, so you can tell her about sinus thrombosis, don't bother by the medical term. Yes, doctor, you can give your patient a medical term, but then explain it by non-jargon. If you didn't, it will be considered jargon. So it is a blood clotting in the blood channels in your head and could be related to a condition that you could have that predispose you to this kind of clotting as well. However, there is other possibility that we need to rule out by doing for you urgent imaging for your head. And I am very sorry to tell you that we may need to keep you at hospital today. And we are here a group of expert doctors that will be looking after you. We have a brain doctor. I will involve him, and eye doctor. And meanwhile, you need to stop driving, Mrs. Sandra, and to stop oral contraceptive pills. And I can involve a woman doctor as well to help you regarding that. So do you have any other, are you okay with that? Do you have any other concern? Do you have any other concern until time finish? Okay. So regarding station 5, so before giving you some advices, doctor, regarding station 5, any question regarding this case? Any question, doctor? I need open discussion here.
Sinus thrombosis is the first thing we said about urgent CT, or think about MRV.
Well, urgent CT brain needed to be done in any case of a severe headache, doctor. Number 1, urgent CT brain. If it is normal, we will go to the MRI and MRV. And this is what you will tell your examiner. So any severe acute headache, urgent CT brain, number 1, and then others. The most important here, MRI and MRV. Okay?
Okay, thank you.
Thank you, doctor. Any other questions, doctor? Okay, so why TIA is not the case here? Could it be TIA, doctors?
Signs
I
of
need
weakness. No weakness in parts.
No, doctor. Well, TIA is painless. there is no headache in TIA, and the patient in station 5 or station 2 coming to you of TIA now will be normal. He will tell you a history that happened 1 day ago or a few hours ago, and there will be no headache. There will be focal neurology either in the eye, in the speech, weakness, okay, even loss of consciousness, loss of vision, whatever, but no headache. No headache in TIA. That's why you need to ask about headache in any case of focal neurology. If there is no headache, so it could be TIA, but if there is headache, TIA excluded. Okay? TIA could happen for 24 hours. TIA, sorry, it is less than 24 hours. Okay? And there is no headache in TIA. So TIA is a painless focal neurology. That's why TIA is not a differential here at all. And TIA has a differential. So if there is a vision problem related to a TIA, if the patient has like a sudden visual loss and he is now totally fine, you will have a differential for that. It could be according to the patient age. If the patient is young, you will put a thrombophilia risk factor, and you will, if the patient has a history of diabetes, you will put a differential of diabetes related, could be whatever related to diabetes, hypertensive retinopathy, you will put other differential. But it is not the case here. Okay. Any question, doctor, regarding this case? Hypoglycemia. Okay, yeah, MS. Yeah.
Doctor, what about acute angle glaucoma?
Acute angle glaucoma, there is headache and there is blurring of vision, but it is not phases-wise.
Oh.
It is not phases-wise. Yeah, it is a good differential, but not phases-wise at all. But a good differential. Differential diagnosis, phases-wise. You are doing phases. Yeah, phases is different from medicine, by the way, doctor.
Okay.
Yeah.
Thank you. Thank you.
Thank you. Thank you, dear.
What about the painless? You said painless eye, like there's no headache. So what else with painless?
The differential diagnosis of painless headache, you mean?
Yeah.
Okay, you will put number 1 TIA, and you will put other differential, like could be psychological, patient could be psychogenic, and could be one of any thrombophilia risk factor causing like central retinal artery occlusion, central vein occlusion, could be optic atrophy, could be papilledema, could be any field defect related to space of lesion, could be retinal detachment, could be any differential.
Multiple sclerosis.
Yeah. Yeah, multiple sclerosis, of course.
Yeah.
So station 5, doctors, it is one of 4, as I told you before. It is either a new diagnosis, it could be a complication of a diagnosis, or it could be association of diagnosis, and it could be a complication of treatment. You need to put that in your mind. So here, as an example, it could be a complication of antiphospholipid, and it is a new diagnosis. So when you have a spot, when you enter the room, when you have a spot diagnosed like acromegalic patient or Cushing or a thyroid patient, so you don't need to do a differential. You will just do the systematic review of your diagnosis that you will see in front of you. So when you have like acromegaly, you will ask about complications of it. But problem in station 5 or the challenging part, it could be a surrogate like this one. So it could be a surrogate with like a function problem, like fibromyalgia, for an example, like whatever knee pain related to something not like physical. You will have no finding to elicit for. So when you have a spot, ask about the disease, the association of it, like autoimmune or the complication of it. And then ask about headlines. Headlines equal past medical history. Ask about it early. It is very important to save your time. Medication list, family history, female history, traveling and trauma history, and social history. All of these needed. And ask about impact. And examine in the first 3 minutes. You need to start examination. In the first 2 or 3 minutes, you need to start examination, whatever the case is. Either if it is a spot or if it is like a surrogate. And you need to be organized. You need to be targeted. You need to be focused regarding your history and regarding your examination to not lose your time. And to do that, you need to practice a lot with correct continuous practicing with your study partner, and to ask each other like examiners and to discuss. So every case will last for 10 minutes, 8 minutes with your patient and 2 minutes with your examiner. 6 minutes with your patient. Put this in your mind, 6 minutes, because the other 2 minutes are saved for concern and for your clinical judgment or your management plan, and even your differential will be in these 2 minutes. That's why 6 minutes to finish your case. Station 5 is super important because it carry 1/3 of mark of the exam, and all the 7 core skills will be assessed in every single case. So you need to expose yourself to a lot of scenarios, and you need to handle each scenario according to its data inside. So it's a game and should play it with the rules. And you have a white paper that you can write down your differential, and you can enter the room with this white paper that you will give the examiners before getting out of the room. So no need to do systematic review in station 5, but you need to you need to do full analysis of the complaint. This is super important. Don't rush and just ask haphazardly about any symptom. Don't do that. This even will demonstrate that you are not practiced. You are not practiced candidate. So ask about the complaint, any complaint in medicine, and write down, doctor, this one. Any complaint in your PACES exam. Number 1 question, is it first time? Is it first time, Mrs. Sandra, to happen to you? After that, onset, course duration, and what increases it, what decreases it, and any diurnal variation. Is it more at morning or evening? Could be a clue to a lot of complaints. Is it on and off or all the time? Okay. And then ask about specific question for every complaint. Like if the case is a headache, a pain like this one, you need to ask about site of the headache, radiation of the headache, and you need to ask about severity of the headache. This is very important. And asking about red flags like any history of trauma, any fever, any skin rash. This is regarding the headache. After that, asking about system of the complaint. So headache and eye are neuro. So you need to ask about other neuro, like do you have any shaking of your body? Patient with sinus thrombosis could have seizures. Okay. Do you have any speech problem? Do you have any weakness anywhere in your body? Do you have any abnormal sensation? I am glad that doctor asked me about bladder and bowel. This is completely okay, but it is a jargon. Actually, doctors, urine, fever, bowel, bladder are jargons. Fever and urine could not be a jargon in UK, but outside, like overseas, your examiner could be a local one. A lot of examiners are not working in UK. Again, a lot of examiners are not working. I know about 10 examiners. They are not working in UK. They had an attachment about even 1, 2, 3, 5, whatever years, and then they are examiners now. They are overseas examiners. So they could consider these as jargon, so try to be very careful with jargon, because jargon, like doctor here asked me, do you have vomiting? So my ears alarmed to that. So if I am bad personality examiner, I could give him borderline in this one, in the clinical communication skill. And clinical communication skill, one of the 7 core skills. And you are very compromised if you use jargon. You could lose the whole exam. You could not pass. You could feel it. Why? Because it is a 16/16 full mark in the clinical communication. 4 mark for each case in station 5. So now it is 8. 4 mark for station 2, 12. 4 mark for station 4. So it is 16. If you use jargon in station 5 in every case, you are compromised, because 11 out of 16 to pass the exam. Again, 11 out of 16 to pass the exam. So vomiting, if you said vomiting, you are very compromised, doctors. Jargon is one of the fatal mistakes that you need to avoid. So vomiting, no, it is a throwing up or getting sick. Okay, urine, it is a waterwork. Fever, it is a rise of body temperature. Bladder, it is a back passage. Urine, waterwork. What else? He didn't do anything else regarding jargon. So what else? Do you have any loss of consciousness? Any abnormal sensation? So you now did in 5 to 10 seconds a survey of neurology. Then you need to start touching your patient by asking permission from the examiner, from your patient, and then asking about headlines at the same time. So you will put your hand in the pulse while you are asking your patient. So I just need to ask you some question regarding your life, Mrs. Sandra. It is okay. So do you have any past medical history of note? You need to ask about this in the first also 2 or 3 minutes. Patient could have a diabetes mellitus. Patient could have a history of something related to the complaint. So if you spared it at the very late, you lost the case. Could be related to the medication. That's why medication list, you need to ask about it in the first 2 to 3 minutes. So number 1 minute, you analyzed the complaint, you asked about your differential that you wrote down in the white paper. And then you will narrow your differential, and then you will go directly to ask about headlines, past medical history, medication list could be the positive, family history could be the clue, female history, like this case was the catastrophic, trauma history, traveling history, and social history. Okay, so practicing, doctor. Practicing is the most important part in your journey. Reading books is useless, is a waste of your time, and is boring as well. Is not effective at all. Okay, of course, you need to read books just to update yourself, to be on the mood. It is totally fine, but don't rely on it alone. It is not, examiner will not wait the next professor of medicine. It is not like that at all. Basis is about to show them that you are fluent, that you are confident, that you are safe doctor, that you are not doing fatal mistakes. Okay? So if you don't know an information, either a patient asked you a question or the examiner and you don't know, don't invent. Okay? Just say, I don't know. I don't know. It is totally fine. So passing basis is in your hands, doctor. You just need to do a right preparation. And if you did it before and didn't pass, this doesn't equal at all that you are a bad doctor or something like this. No. Basis is something, there is luck in basis, of course. It is according to the case that happened to you, to the surrogate, according to the examiner, according to your own mood in the exam setting. So basis is not about how good you are as a doctor, no, not at all. But passing it is in your hands as well. Because if you are well prepared, expose yourself to a lot of scenarios, did your best, so you're with a discipline, so you have a higher chance to pass. So like Barcelona versus Real Madrid, both are brilliant, but one of them will lose mostly. So it is not, could be your day, could not be your day. But you need to demonstrate to the examiner, you need to satisfy them. Put this in your mind, doctor, it is a game. It is like only 1 hour, the whole exam will be passed like a second. So you need to, in these seconds, in these minutes, you need to satisfy your examiner. They need to look for you that like you are a safe doctor, you are a competent doctor, you are ready to practice in the specialty training in UK. They can rely on it. They can have a discussion with you as a registrar in UK. That's why don't play a victim mode. Don't look at the ground while they are discussing you, no. And don't be arrogant at the same time. You need to just be like natural doctors, especially station 5, because it could be a real 2 patient. And just imagine that it is in your daily clinic or daily round in your hospital, and the examiner are your colleagues. That's how to do it. Don't ever wait a feedback from the examiner or look at the examiner while you are doing your case. No, they will not give you a feedback at all. They will not encourage you. And keep in your mind that you need to concentrate just to your patient. Okay? And most of the examiners will want to pass you. This is true, doctors. Of course, there is a full range of personalities you will be exposed to, but best advice, doctor, to not worry about them at all. Focus in your patient and know that you can do it. And you don't need to be perfect to pass the exam. You don't need to be perfect. Mistakes could happen. You have 40 degrees to pass the exam, no problem. You can mess up 2 stations and pass the exam. But there is some skills, as I demonstrated earlier today, like clinical communication, do not tolerate a lot of mistakes. That's why a lot of colleagues, you all know, even the marking could be 150 and didn't pass the exam. That's why you need to put in your mind, you need to read the mark sheet. There is in the websites of MRCP UK, there is a mark sheet. You need to read it carefully. And if you did an attempt before, you need to ask for the feedback, the official feedback of the Royal College to work on the weak areas. Every one of us will have a weak area that you could have a weak area in time management in station 5, for an example. You could have like a weak area in the communication. So that's why you need to be ready. You need to practice a lot. You need to be ready for any possible scenario, either in station 2, 4, 5, and of course the clinical scenarios. Okay. Any questions, doctor, before I leave? Okay, I recorded this session. I will share it with you, inshallah, after going right now. And my glad, doctors, to have you all of you today. I really have the pleasure to have you all in and hope for you all, inshallah. And be motivated, doctor, keep it up and keep practicing. Actually, you did the big part. You already passed part 1 and part 2. It's about only pages. So it is a tricky situation. Okay? So you are not in the bottom of the problem. I know COVID is a problem and you could be distracted right now, you could be exhausted, but keep it up. Get yourself in the mood. And to do that, you need to practice. It is the most effective way to decrease your stress, either in the exam or in the period of preparing for the exam. It is about subconscious mind, repeated wise. So try to practice a lot, doctors, with your study partner, and have you, see you soon, inshallah, doctors. I will announce another session, inshallah. Thank you, doctors.
Thank you so much, Dr.